Delighted to be introducing to you the chair of the next session, who you've met before, Professor David Maybe, past president of the RSTMH and member of the Board of Trustees, chair of the Education and Training Committee. He's going to introduce our next session. Thank you very much. Welcome to David.
Thank you, Tamar. It's a great pleasure to introduce Professor John Crump, who's a professor of medicine, pathology, and international health at the University of Otago in New Zealand, and also adjunct professor at Duke University in North Carolina. I first met John when he came to take the DTM&H course in London in 1995. And at that stage, he had qualified in medicine just 2 years earlier in New Zealand. After DTM&H, he went to work on the infectious diseases ward at the Royal Free Hospital, just up the road there. He then went back to do microbiology in Australia, and then went to Duke University in the USA to complete his training in microbiology and infectious diseases, and then spent 2 years at the Centers for Disease Control in the USA. He then went to set up a link between Duke University and Kilimanjaro Christian Medical Center University in Moshi in Tanzania. And he spent 10 years based in Moshi, and this was about the time when point-of-care tests became available for malaria. So before that, as I remember working in West Africa, a patient with a fever had malaria, and you treated them for malaria. And if they didn't get better, you thought perhaps they had something else. But John came in when point-of-care tests were available, so it was clear that most patients in Moshi did not have malaria. And he really laid the groundwork for studies on the causes of fever. He showed that there were many cases due to brucellosis, rickettsial infections, leptospirosis, and he's gone on to establish the incidence and the burden of disease due to these infectious diseases. So it's a great pleasure to introduce John, who, in addition to doing all that amazing research, trained a large number of younger colleagues in Tanzania and around the world during the course of his career. So he was the winner of last year's Chalmers medal, which I was supposed to present to him, but I seem to have left it down there. So it's in my bag there.
All right, good afternoon, everyone. It's a real pleasure to be here, and thanks for the opportunity to say a few words and for the kind introduction, David. I've been a fellow of the Society for almost 30 years, since the time I did the DTM&H course, but I don't often get to these events in person, so it's really nice to see so many of you. Preparing this talk caused me to reflect on two related themes. The first, of course, is mentorship and capacity building that the Chalmers Medal seeks to recognise. And the second relates to the important but sometimes painful process of improving how we work. This may have led a conscientious person to forget why we work in the field that we do. One of the existential crises I wanted to talk about, among many others today. So in the latter part of the talk, I thought it would be useful to revisit the moral basis for global health engagement. So I'll aim to tackle these two themes using my research interest on non-malaria fever in the tropics as a structure. So my interest in non-malaria fever in the tropics doesn't really have a single origin story, But when I moved to Tanzania more than 20 years ago, as David mentioned, I wanted to contribute to a challenge faced by my Tanzanian colleagues. And I was often told about and quickly understood that the patients were many, healthcare workers were few, laboratory services were limited. And in this context, fever was a common reason for patients to seek care. And indeed, this slide shows the occurrence of diarrhea, cough, and fever among more than 1 million surveyed children aged less than 2 years in low middle income countries during a period of several decades. And fever, shown in red, is a common symptom reported in more than a quarter of children in any 2-week period. And as you can see, while fever often occurs with cough or diarrhea, in any given 2-week period, 7% of children have isolated fever in the community, and some of them end up seeking health care. But unfortunately, as we know, a patient with fever poses a diagnostic challenge anywhere in the world, but especially in the tropics where fever is a common reason for seeking care. This patient's been admitted to a district hospital, and the temperature chart shows he's had fever for several days. And I don't need to tell this audience that fever is a symptom of many infectious and some non-infectious diseases, and that these can be difficult to accurately distinguish from one another by just keeping a history and examining the patient. And in lower resource areas, the problem's compounded by the limited number of healthcare workers, high patient volumes, few diagnostic laboratory services mentioned earlier. And it's interesting to reflect on what the World Health Organization guidelines recommended in this clinical situation back when my interest was sparked in the topic by my Tanzanian colleagues. The WHO guidelines for the treatment of malaria 2006 had this to say: the signs and symptoms of malaria are non-specific. Malaria is clinically diagnosed mostly on the basis of fever or a history of fever, and the recommendation could be paraphrased as fever in the tropics should be assumed to be malaria and treated as such. But my Tanzanian colleagues in the Department of Medicine had identified that patients admitted with fever at this time were doing badly. They suggested that we work on this research question: why are we seeing bad outcomes among patients with malaria? So one of my early projects together was to systematically look at causes and outcomes of febrile illness at Kilimanjaro Christian Medical Centre and Mwenzi Regional Referral Hospital in Moshi. My colleague Hugh Rayburn from the London School ran a similar project down the road in Muheza. In Moshi, we looked at healthcare worker admission clinical diagnosis versus high-quality laboratory diagnosis of febrile inpatients. We carefully studied 870 hospital admissions using diagnostic methods at national and international reference laboratories. We found that healthcare workers clinically diagnosed and treated almost 2/3 of admissions with fever as malaria, shown in red. But using blood smear and malaria rapid diagnostic tests, we found that actually only about 1.6% of patients actually had malaria, also shown in red. In brief, the major reason that patients with malaria were experiencing bad outcomes at the time was that most patients clinically diagnosed with malaria didn't have it. And this was perhaps not surprising given trends in malaria at the time. By way of illustration, these heat maps show Plasmodium falciparum parasite prevalence globally among 2 to 10-year-olds, modelled from community surveys for the year 2005 in the top panel and 2017 in the bottom. Areas in grey are essentially malaria-free. Those in red, the proportion of the population positive for malaria parasites approaches 100%, whereas parasite prevalence approaches 0 for areas in blue. You'll note there's a marked cooling of the colours in sub-Saharan African countries between 2005 and 2017. Considered in concert with the previous slide, a key message here is that the role of malaria as a cause of febrile illness had not only substantially declined between 2005 and 2017, but it was also highly heterogeneous and in fact absent or uncommon in large swaths. Where malaria has declined or was uncommon, the proportion of patients with fever who have infections other than malaria is of course increased. And these findings and others combined with the switch to artemisinin and combination therapies and malaria rapid diagnostic tests contributed to the major change in the World Health Organization guidelines for the treatment of malaria in 2010. The revised recommendation was that antimalarials be prescribed based on the result of a malaria diagnostic test rather than just on the presence of fever alone. To quote, prompt parasitological confirmation by microscopy or rapid diagnostic test is recommended in all patients suspected of malaria before treatment is started, and treatment solely on the basis of clinical suspicion should be considered when a parasitologic diagnosis is not accessible. But of course, this new guidance immediately raised a new problem for healthcare workers. What to do with a patient with fever and a negative malaria diagnostic test? When tests for malaria were rolled out, it was quickly found that in many places, a majority of patients with fever did not in fact have malaria. For the few patients with a positive test, the way forward was clear: prescribe an anti-malarial. But for the vast majority with a negative test, healthcare workers without a laboratory were stuck to know what to do. And without a picture of the major causes of severe illness associated with fever, it was very difficult to know. And this question has underlined much of my research since that time. So returning to our foundational study, what major non-malaria causes of fever did we find among inpatients in Tanzania at the time? Well, about half of the fever patients were confirmed to have the infections listed here. Notably, healthcare workers rarely considered or diagnosed most of these non-malaria infections, and many of them were unfamiliar. This foundational study led to streams of work on disseminated tuberculosis, typhoid fever, invasive non-typhoidal salmonella disease, and others. And the finding that bacterial zoonoses like brucellosis, leptospirosis, and Q fever accounted for a large proportion of confirmed infections, and that these infections are transmitted to people from livestock, rodents, and other animals, sparked a raft of One Health research, spurred by the dual impacts of direct human health consequences, as well as the major impacts on survival, growth, and reproductive success of economically important livestock species in Tanzania. I'm grateful for Tanzanian and international mentors and trainees for this rewarding stream of collaborative work that's launched the careers of a number of trainees. And while I don't plan to discuss this work, I'd like to thank my long-standing colleagues, Venance Maro, Matt Rubach, the late Ludovic Kazwala, Sarah Cleveland, Blandina Mbaga, Joe Halliday, Ding Madut, Kath Allen, among many others. But for my comments on mentorship and capacity building, I wanted to touch on a specific facet of our current work on febrile deaths. So when we looked at febrile deaths in the foundational study from 2007-2008, we realised that such studies of severe febrile illness leave many febrile deaths unexplained. In our study, about 3/4 of infant and child deaths and almost as many adolescent and adult deaths occurred without a microbiologic diagnosis for the cause of death. The reasons for this reflect the limitations of diagnostics for acute deaths. For example, infections that rely on confirmation by paired serology can only be studied among survivors. And infections present after the peak period of bacteremia are challenging to confirm later by culture or nucleic acid amplification, infections like typhoid fever and leptospirosis. The consequence of these limitations was that we knew the least about the group that we would like to know the most about if averting deaths was a goal: those who died with febrile illness. So we formulated a plan for a febrile deaths autopsy study. The idea of an autopsy study might not have occurred to us as feasible, except that I'd been exposed to a number of infectious disease pathologists, possibly most of the infectious disease pathologists in existence, who had inspired me, mentored me, or both early in my career. Sebastian Lucas, who taught on my DTM&H in 1995 at the London School, when David Mabey was course director, along with others, had described his work on Projet Retro C, undertaking epidemiologic autopsy studies of clinical pathology and HIV disease in Abidjan, Côte d'Ivoire. Then Anne-Marie Nelson, who taught me infectious disease pathology during my medical microbiology fellowship at Duke University. She had worked on Projet SIDA, leading a descriptive pathology study of AIDS in DR Congo in the late 80s, early 90s. And then finally, the late Sharif Zaki, who was head of infectious disease pathology at the US Centers for Disease Control during my time as an epidemic intelligence service, and whose interest in the application of infectious disease pathology to cryptic deaths and outbreaks was well known. So we managed to co-opt both Anne-Marie and Sharif into our project called Investigating Febrile Deaths in Tanzania. In so doing, a number of early career pathologists were mentored. Alex Mremi, head of pathology at KCMC, Kilimanjaro Christian Medical Center, his pathologist colleague Patrick Amsey, as well as Christina Costales, a pathology resident from California who we engaged through the Fogarty Global Health Fellowship Program. I'm just going to give you a flavour of the science that is coming out of this autopsy project that's ongoing. It does come with a health warning though. There's some gross pathology images coming up. So if you don't want to see those, just listen and avert your gaze. So to give you a flavour of the science in this project, here are 3 vignettes among many febrile deaths completed so far. The first, a 35-year-old male nomadic pastoralist with a history of a vesicular rash developing a black base below the left eye, and throat and neck pain for 4 days, progressing to dyspnea and loss of consciousness for 1 day. The gross appearance of his brain at autopsy was consistent with a hemorrhagic meningitis, and the affected periorbital skin H&E histology at 6 times magnification showed periorbital cutaneous eschar with extensive necrotizing inflammation and ulceration. Not shown, we also found laryngeal tissue edema and lymphoid hyperplasia. The lungs had extensive neutrophilic intraalveolar inflammation and focal hemorrhage, and the brain showed a hemorrhagic neutrophilic meningitis with fibrinoid necrosis of cerebral arteries and arterioles. Culture of blood, CSF, lung and brain grew tenacious white-grey comet tail or medusa head colonies that were non-hemolytic. Catalase test was positive and the bacteria non-motile. Bacillus anthracis was subsequently confirmed by PCR of an isolate for toxin genes. Next, a 24-year-old female agropastoralist reporting a spontaneous abortion 1 month prior to presentation with jaundice for 5 days. At autopsy, the liver appeared pale and boggy with diffuse micronodules. Liver H&E histology here at 40 times magnification showed confluent submassive hepatic necrosis. And immunohistochemical staining was positive for Rift Valley fever antigen in necrotic hepatocytes. Multiple tissues were PCR positive for Rift Valley fever virus, and Rift Valley fever virus was subsequently isolated in tissue culture. Third, a 59-year-old female with HIV infection and virologic failure presenting with fever, headache and altered consciousness for 5 days. The cryptococcal antigen test was negative on cerebrospinal fluid. H&E histology at 80 times magnification showed focal hepatic necrosis, moderate periportal mononuclear infiltrate, early possible bridging fibrosis, and patchy steatosis. Immunohistochemical staining was positive for Coxiella burnetii antigen from affected tissues. And PCR was positive for a Coxiella burnetii target in multiple tissues with low CT values. Later this year, we will attempt Coxiella burnetii isolation from these tissues. But besides the kind of interesting and hopefully useful science once we get it done, Alex and Patrick now use the telepathology capacity on the left panel, developed through the project to consult with pathologists anywhere on difficult cases, and hopefully to inspire some of the many medical students at Kilimanjaro Christian Medical University College shown in the right panel to become pathologists themselves. So I think it's this kind of virtuous cycle that connects people who inspired me more than a quarter of a century ago to those early in their careers who will hopefully achieve and contribute much more than any of us ever could. And I think whenever we're weary with mentorship and capacity building, it's worth reflecting on these impacts that may seem imperceptible at the time and often occur over very long time frames. Oops. I wanted to finish by touching on existential crises. As I mentioned in the start, our discipline's been undergoing the painful work of considering historical and structural questions about how we work and making changes. And if you were like me, you probably read the stream of provocative, thoughtful and sobering material on decolonising global health and related areas during the surreal years of the COVID pandemic. Some of the pieces that I read are clipped here. And I think it's sometimes difficult as a conscientious person to wonder if reallocating efforts elsewhere might be for the best. It's possible that a negative consequence of doing so would be to give further momentum to the present retreat towards nationalism. And my New Zealand global health colleagues and I thought about this a lot during the pandemic, and I wanted to tell you a story that I think's illustrative. The New Zealand pandemic response and policies were characterised as largely a success, achieving favourable outcomes for New Zealanders in terms of COVID illnesses and deaths averted. And the approach used was roughly aligned to that of liberal nationalism, an idealised and inclusive form of nationalism that achieves social solidarity by mitigating and operating above ethnic, racial, religious and other differences. Practically speaking, this was constructed through a range of measures, including, for example, appeals to national identity. For those who aren't aware, New Zealand national identity is founded in sporting success and war service. The former was drawn upon through a national campaign promoting the concept of a team of 5 million. This is a sports metaphor encouraging national unity behind a cause that was derived directly from slogans used to promote the Rugby World Cup in 2011 and the America's Cup in 2021, both held in, and in case you missed it, won by New Zealand. While engendering national solidarity, this envisaged the COVID-19 control as, as an international competition in which New Zealanders sought to emerge victors. One author opined in late 2020 that New Zealanders daily checked the national scoreboards of infection rates and death tolls with smugness. Similarly, aspects of national identity rooted in war service were invoked through the use of war metaphors like "our allies have let us down," framing New Zealanders as taking a last stand alone in a war lost elsewhere by allies. And I think you can see where this is going. So the strategy quickly imagined the non-New Zealand world as a marginalised outgroup. This sentiment was exemplified in this quote from March 2020. "If we can stop that and make sure we don't have the disease here, we'll be able to live life relatively normal while we watch the rest of the world burn." Now, this headline-making pronouncement didn't raise eyebrows at the time, and in fact, its originator was made New Zealander of the Year in 2021 for contributions to public science communication, which were otherwise exemplary during the pandemic. Time doesn't allow me to go into further detail about this, but you can read more about it in our piece published in Nature Medicine last month, reference in the lower right corner of the slide. In brief, an epidemiologically successful pandemic response that protected New Zealanders did little to help non-New Zealanders. Indeed, a response founded even in liberal nationalism was in many respects at odds with a successful global response to a transnational problem. This caused us to reflect again on why we work in the field that we do. What is the appropriate moral basis for contributing to global health? Well, realpolitik aside, we considered that the philosophical idea of cosmopolitanism as a useful counterpoint to nationalism and a moral basis for global health engagement. A cosmopolitan perspective views all humans as members of a single community, every person having global stature as the ultimate unit of moral concern, and thus being entitled to equal respect and consideration no matter what their citizenship, status, or group affiliation. Here, distance is morally irrelevant, and we're encouraged not to let local obligations crowd out responsibilities to distant others, and our responsibilities extend even to those who we don't know. So I'd like to finish with this slide from Gapminder, displaying one health indicator, national human lifespan, by per capita income for 2021. New Zealand's highlighted with a black box and the UK with a black circle. And for the time being, we're reminded that there remain heavy responsibilities to afford equal respect and consideration to distant people we don't yet know and who experience poorer health outcomes than we do. Figuring out how best to do this, of course, remains our continuous task, and we look to our trainees to do both more and better than we have done. So I've got gratitude to many, many people who've helped me along the way, but I'm mostly going to just acknowledge people in groups for the interests of time. I'd like to thank my mentors over many years, including those at the University of Otago, the London School of Hygiene and Tropical Medicine, Duke University, the US CDC, my colleagues at Kilimanjaro Christian Medical Centre, University of Glasgow, Sokoine University of Agriculture, University of Medicine One in Yangon and beyond, my past and current students and postdoctoral fellows, the funders of our work, please keep it up. David Mabey, DTM&H course director at the London School in 1995, for encouragement over many years and for this nomination, and to the Royal Society of Tropical Medicine and Hygiene for recognising the work through the Chalmers Medal. Thanks for your attention.
Thank you, John. That was wonderful and inspirational. We won't talk about the Rugby World Cup on this occasion. Tamar, I'm not sure if we have time for questions. We're running a bit late, aren't we? We do? 5 minutes for questions. Any questions for John? Well, yes, question at the back.
Hi, thanks so much, John. This is Catherine from Malaria Consortium. In terms of the work that you're doing around the autopsies for febrile deaths, can you speak a little bit to the methodology you're doing? Is it a case series, or are you collecting all febrile deaths in certain clusters? Or I'm just interested to know what the sort of method is for capturing deaths. Thanks.
Sure. Yeah. So it's a hospital-based study. We've actually it's got two pathways of entry. One is if you're admitted with fever and die, and the other is if you die before you've been entered in through the fever study. And we attempt to capture everyone during the period of the study meeting one of those criteria. We'd hoped to have considerable overlap between the group presenting with fever and the group who have autopsy, but actually they're somewhat overlapping, but not the same group. So the enrolment of the cohort's finished. We have about 200 autopsies, and we're working our way through the pathology. H&E staining and special staining is being done in Tanzania as part of the capacity building for the project. The infectious disease pathology, the kind of stuff we're doing is fairly boutique, and so that's being done at a reference lab with telepathology sharing back and forth, and that's taking a long time. So we're still going, and along the way we sadly lost our colleague Sharif Zaki, who, if any of you know, is a wonderful person, like all infectious disease pathologists I've met, and so picking up the work in his absence has been a challenge, but we hope to get there, and I just gave you a flavour, I think, for what we've been finding.
Microphone coming.
Thank you, John. What a nice talk. You know, in your slide, there are the causes of fever, the other causes of fever besides malaria. I did not see typhoid. So
I'd included, I had a bucket category called bloodstream infections, And I didn't explode it in the interest of time, but actually during the period of the study, Salmonella typhi was a common cause of bloodstream infection in this location, which is interesting because we, I think, tend to think of non-typhoidal Salmonella bacteremia, but this is a low malaria location. And, yeah.
So you were one of the first people to show that there is, typhoid that should be reckoned with in Africa.
Yeah, it's been an interesting story because it's not long ago people were writing papers saying typhoid doesn't seem to be a problem in Africa, but actually that was partly, I think, because people hadn't looked hard enough. Then there was the story that typhoid's an urban problem in Africa, and yet when we start looking in some rural areas, we find typhoid there as well. So it's been really an unraveling picture as people have done more work.
And you found typhus too, right? Rickettsia.
Yeah, so spotted fever group rickettsia. We're still in the process of trying to figure out which species predominates in Tanzania. And we haven't done a good job, but the ones we've been able to confirm so far have actually been Rickettsia connorii and not Rickettsia africae. We don't see a lot of Rickettsia typhi in this location, but past studies in Dar es Salaam, a much bigger city than the place we work, have shown murine typhus to be quite common there.
Scrub typhus?
We haven't found any. There are other studies that are looking, yeah.
Yeah, thank you very much for your lecture. I was just wondering, reflecting back, what are the challenges you faced with all these autopsies?
Yeah, so first of all, I'd mention a lot of social science work went in to understand community perceptions of autopsy in this area. We found that this is quite a receptive area to autopsy for a number of reasons, including there had been a long tradition of autopsy being done for medico-legal reasons at the hospital, but also very supportive Muslim, Christian, and other religious leaders who saw the value of autopsies in improving the management of future patients. The other surprising finding from the social science work was people viewed autopsy as a means to exclude witchcraft as a cause of death, which was apparently very reassuring to families. And so autopsy was commonly accepted for that reason. In terms of practically speaking, there was a lot. The hospital we were working at had not had a Tanzanian pathologist for a very long time. And so we had 2 young pathologists coming back, and on the positive side, we were able to support them to refurbish the pathology department and help them to be exposed to infectious disease pathology. On the challenging side, they were the zonal referral pathologists for a huge part of the country and had massive workload. And so I think part of the challenge that they face is inspiring medical students who aren't often attracted into pathology to want to do pathology so that the workforce could be expanded. And of course, infectious disease pathology was just part of what they had to deal with. They had all the cancer pathology for a massive part of the country and so on. In terms of full diagnostic autopsy versus minimally invasive tissue sampling or using trocar needles, we offered the latter as a backup for families who didn't want their loved one to have a full autopsy, but we actually found full autopsies in this area were quite acceptable, and we only occasionally defaulted to minimally invasive tissue sampling with the trocar.
Last question here, I think. Thank you. Another microphone.
So I think probably the first big achievement was quite a few years ago, and that was just recognizing that malaria was a relatively uncommon cause of fever and to think about other things. And there was actually a national campaign that translated to English means not all fevers are malaria that was televised and so on to sensitize patients and families. So that they were aware of that as well. I think the next was becoming aware that doxycycline responsive infections like spotted fever group rickettsia, Coxiella burnettii, and I showed you a Q fever death just now, were actually pretty common, and yet that drug doesn't really feature at all in syndromic management algorithms for febrile illness in Tanzania, or let alone most countries in sub-Saharan Africa. So I think reducing the threshold for use of doxycycline was helpful, and I haven't gone into the kind of epidemiologic predictors of those infections, but they're kind of what you might expect. It's very interesting that spotted fever group rickettsia and Moshi peaks in late infancy and early childhood, so a lot of the people getting that infection are actually not necessarily the ones that I would think of, they're very young kids. And then, the next question is where to go with biomarkers or diagnostics is challenging, and I think part of it is that there just hasn't been the level of investment in point of care tests for some of these other major causes of fever. Some of them are technically challenging, others I suspect it's just that there hasn't been investment. And then, for biomarkers, I think figuring out which patients have bacterial infections would be really useful, and more particularly, not in the hospital setting, but further down in the healthcare system to identify from which patients antibacterials could be safely withheld. Here I'm talking about not the severe group in hospital, probably be very difficult to safely withhold in that group, but out in the community where a lot of these medicines are used would be another. And then there's the whole prevention side, and we heard in the last session that there's not very much attention on the use of vaccines in animals to prevent human infections. But of course there are examples in a lot of high-income countries of controlling leptospirosis by vaccinating livestock. And leptospirosis in northern Tanzania is primarily a livestock-associated disease, not a rodent-associated disease. So there are all kinds of opportunities for the zoonoses that I think we don't tend to think about, and it's not obvious how you get investment in those. But there are some quite interesting prevention strategies that I think are worth thinking about.
I think we're at time now, David. Sorry.
Time is up.
Time is up. I'm sorry.
Okay, thank you, John. That was wonderful.